So today's session is all about the rationale for using group care to address winter pressures. And in fact, today we're going to be hearing from clinicians talking about using group clinics, just as Helen's explained, and also a model which is more akin to an education, group education model that has been used in London to help to support parents to manage common childhood illnesses across the winter. What they did do, though, was they based that on the group clinic approach, whereby there was very little use of slides and it was all about discussing what the group wanted to discuss. So it was a little bit more of a person-centered approach to group education. So before we just go into meeting the speakers, I just wanted to just spend a couple of minutes thinking about the rationale for using group care to address winter pressures. It's interesting, isn't it? Because, we know winter pressures are going to come every year, and somehow, we start to talk about them in about sort of September, October time, when we've got our flu injections behind us. But we actually know that they are coming every year, and we can be also these days very, very clear about the patients who are at most risk during the winter based on data that we have now. We have so much better data around who's going into hospital, that kind of thing. So the question is, perhaps, could we actually be doing more, maybe earlier in the year, to help our patients to prepare for winter? And even during this period leading up now, what could we be doing to get them ready so that they really feel confident about facing the winter and managing their health issues? The good news is that group clinics lend themselves really well to supporting patients to take a really proactive, a preventative approach to their care. In fact, the evidence shows that patients do better at self-management after they've been seen in a group clinic compared to a one-to-one appointment. In a group setting, people also tend to learn more because it's more interactive, they engage. There's something for everybody. Depending on what your learning style is, you can listen and reflect, or you can be more proactive and talk and get what you need from the group. And you get the benefit of the wisdom in the group from the peers as well as from the clinician who has strategies and ideas to offer the group. Group clinics build self-efficacy. We know that when people use things like PROMs and oh gosh, what's that score? I'm having a blank moment here. The score that shows your level of self-efficacy. Somebody will probably pop it in the chat to remind me what it's called. That actually group clinics raise that very effectively, and people who are at high risk really benefit. That's the one, Laura and Rupa. Thank you so much, Pam score, from knowing that they're not alone. So you'll hear that, I'm sure, today from both Laura and Rupa when they share experiences of their patients who have attended their group clinics recently. They're also a really efficient way for us to work because we get to see a lot of people and do a lot of clinical work in a short period of time. And if we do, God forbid, ever face lockdown again, which hopefully we won't, but even if we're dealing with vulnerable patients who might be feeling a bit scared still to come to the surgery, video group clinics can be a really safe way of seeing our patients and sustainable when risk of infection is high. So those are some reasons to think about using group clinics. And I'm sure that when you hear the stories of our expert mentors today, you're going to be really inspired to give them a go. So without further ado, we're going to move to listen to Rupa, I think, if we let the slides go on. So Rupa, over to you.
Thank you, Georgina. I just wanted to check that you can hear me okay. Excellent, excellent. So my name is Rupa Joshi and I'm a GP based in Berkshire West. And I started my journey in group clinics back in 2018. And I actually started with asthma and paediatric group clinics. And it was really interesting to see the data from one winter to the following winter after just one group clinic for some children which were in high-risk groups. Next slide, please. So what we did was this particular clinic was face-to-face, but we did do virtual group clinics as well. So through the pandemic, we did choose our high-risk asthma patients, adult asthma patients, and we made sure that we invited that cohort of patients to have video group clinics. And we also did paediatric video group clinics for teenagers, where we had all the children with their sort of headphones on, typing into the chat, which was really effective because they really interacted very well on that platform. But what I'm going to talk to you about today is our face-to-face group clinics. Next slide, please. So what we did was as Georgina said, we looked at our data. And what we realised was that there was a group of patients that were bouncing in and out. They were coming into the surgery. They were calling 111. They were going into paediatric A&E. And when we looked at who was attending for our QOF asthma reviews, it was really difficult to get these patients in. What we were finding is that they were actually just pitching up in crisis. They were DNAing or not answering the recalls, the QOF review recalls, but they were just coming in crisis. So what we wanted to do is target those patients. So target those patients that had been on prednisolone 3 courses in the last 6 months, those that were going into A&E, those that were going into hospital. And also, as part of our medicines management, we were also looking at the number of Ventolin and salbutamol inhalers that patients were having. And so what we were looking at is those patients that were having more than what they should have done on their salbutamol inhalers. Next slide, please. So we looked at those patients and we invited them into our group clinics, and we did them age specific. So we did 4 to 6 year olds, 6 to 8 year olds, 8 to 10 year olds. So we grouped them all together. And this was our session flow. We welcomed the patients in, and they came in actually via the height and weight monitors in the clinic rooms. So as they came in, we knew what their heights are, what their weights were. And our facilitator welcomed the patients in. We got them to do a peak flow so that we could see whether they knew how to use the peak flows properly. We got them to do inhaler technique, and then we got them to ask lots and lots of questions, and it was really interesting to see the questions they were asking. So this was the children and the adults. And what we found is in a group clinic setting, they were kind of asking the questions that we wouldn't really expect them to in a one-to-one. So they were saying things like, can my child still go swimming when they've got a cold? Is it good to wear a scarf to stop the bronchospasm? So really basic questions that we thought, well, that's not what they normally ask, but they felt comfortable enough in this kind of group setting, a non-medicalized, personalized care setting, that they could ask whatever they wanted to. So after asking the questions, the clinician would join and go through themes of questions with the cohort, and then the clinician would then do a one-to-one asthma care plan. So what we did was we printed out the Asthma UK care plans, put them on all the chairs, and then the parents with us helping them fill out the asthma care plan. So what's your peak flow? Write that in. What's 50% of your peak flow? What's 70% of your peak flow? And what we found was it was really interesting that the patients realised that there was an amber section. Before they had to go to A&E, there was a point at which we could then intervene, where we knew that this was more than 70% of their peak flow. What we could do is increase the inhalers. We could get them to look at their peak flows continuously to see whether they were falling. So there was a point where they could intervene, and that could then stop them getting unwell that could then stop them going into hospital. And it was a very personalised care approach. So each patient then had a goal where they could set, after answering the questions and theming the questions, there was a personalised goal that everyone could go away with, and knowing that they could improve their asthma care. And then it lasted about an hour and a half, as we said. Next slide, please. So this is our paediatric asthma results board. We did give them the 3 questions that you do for your QOF review. So we asked them to fill that in. So we put those on the asthma results board. Height and weight we talked about as we came in. Had they had a flu jab? And we squirted patients with the nasal flu if they hadn't had it already within the group consultation. And we talked about how many prednisolone courses, how many inhalers in the last year, how many hospital admissions, what's your peak flow, any allergies. And one of the things that we noticed was in this cohort, children with nut allergies or dairy allergies, it was really important for them to make sure that they had their asthma review, because if they did get an allergy, we wanted their breathing to be stable. And what we found is that's something that they didn't really understand. They didn't understand that if you kept your prevention inhalers up, then it wouldn't result in that kind of anaphylactic breathing worry if they were well controlled. And we also had whether they carried an adrenaline injection pen and what other medications they were on. Next slide, please. And these were the 3 questions that we asked them, and this was a way of making sure that we were doing these on the same day that they have their asthma review. So it all ties in with the QOF points. And so this was something that they had as a questionnaire to fill in at the beginning of the group consultation while we were waiting for everyone to come on board. We talked about pets, we talked about smokers, smoking cessation within the family as well. Next slide, please. So what was the result of these questionnaire, these baseline scores? We noted that a lot of the children were having difficulty sleeping because of their asthma symptoms. They were experiencing those wheeze, chest tightness, coughs during the day, and the majority of them were interfering with their usual activities. So this could be school, exercise at least once or twice a week. So that was 50% experiencing daily interference with their symptoms. Next slide, please. So after we'd collected some of this data, and we looked at these, the people that we saw within this winter months, and then we compared it with the following winter months, we were really pleased with just this one intervention making a big difference. So the Ventolin inhalers went down from 18 to 8 over those last over that 12 months. Pre-intervention, there were 12 recorded hospital admissions, and in the 12 months afterwards, that had dropped to a remarkable 0. And the GP attendances had dropped from 9 to a remarkable 0, and the patient feedback was excellent. So you can imagine if we scaled this intervention up, and this was just from those cohorts that we did, very small numbers, that we went to 0 from GP attendances, and we went to 0 for hospitals, 111, A&E. Nobody who had been bouncing in and out of hospital from 1 year had to go into hospital the subsequent year, because they had done a personalised care approach. We'd explained things to them properly. They'd had a chance to answer the questions, and this was compared to a one-to-one and a group. And those that hadn't responded to these invitations came to these group clinics. It was something different that we were offering, and they really liked it, and the feedback was excellent. Next slide, please. Right, I'll pass over to Laura. Thank you. Thank you for listening.
Are you good to unmute, Laura? Brilliant.
I'm here now. Yes. Hello. Hi. So I haven't got slides because our COPD groups only launched last week. So I was going to tell you more about where we started and how we ended up getting to where we were last week. And hopefully in 6 months' time or next year, we'll have some sort of data like Rupa had to show some benefits. So our history, oh, sorry, Helen, and can you keep me to time if I talk too much, please? Can you interrupt me? So where did we come from? So our surgery, we followed the training with ELC about 6 years ago. We followed it to the letter. There were 4 surgeries attended, and we were the only surgery that carried on because we set a date and just went for it. So I really would recommend that. We started with diabetes, and we were very clear then that our numbers were too high for me to see all the people with diabetes. I was the only person seeing patients with type 2 and starting to see people with type 1 at that point. And 20 minutes wasn't long enough. And it's actually, from a clinician point of view, it's quite a hard slog to see patients back to back, one after the other, and you're repeating yourself. So we're really keen on the group consultation, this group clinic setup. And it was clear from our one-to-one appointments, people just don't retain everything we say. There's a lot to fit in 20 minutes. And they'd come back the next time and you'd be saying the same things or thinking, well, I wrote that last time, but you don't remember me telling you. And this became more and more evident with the group discussion. So when we first started diabetes groups, the first question every single time was, what's an HbA1c? And I'd been seeing these people. I knew that I'd explained it in the past and talked about readings. And I was always driving the discussion. So it worked. We changed it. We carried on doing groups virtually throughout lockdown. So our patients were still getting all the care they needed. And from my point of view, it's so much more satisfying to have an hour-long discussion with 10 people rather than talking at them a lot of the time in a 20-minute appointment where I've got to fit in the QOF and their answers and such like that. So it's been working really well with diabetes, and we're starting to gather more data. Unfortunately, lockdown did have an impact in our pushing forward with asthma and hypertension and COPD. So where did we get to is this year I was looking at, I had 300 people thereabouts with COPD who needed a pre-winter MOT. And with staff changes and training up the team, there just weren't enough people to see this group of patients. And again, we seem to have lots of people with exacerbations. So we've done a lot of work around salbutamol use and rescue packs. So we'd managed to cut down the rescue packs a bit, but we weren't really making big inroads. The main reason we hadn't launched a COPD group previously was because our room is upstairs, and we know that in a trial people were just so puffed when they got upstairs. It took them a good 10 minutes to recover, and some people just turned around and left. So we decided we had to meet the needs of these 300 people. The winter pressure was really worrying us. So we decided to hire a room at the town hall, and from start to finish, we started this plan a month ago, and we launched our first groups last week, and we saw 4 groups back to back and learnt loads from this. So we did just follow the plan, and we will be improving it. The model we've followed is, for us, groups aren't a short-term fix, they're a long-term plan. So if things fail, we use the session improvement planner to really think, well, why do we feel it failed? What were the good points? What did we do well? And what could we improve? And we've invested a lot of time into each disease area that we've launched. We haven't gone through all the session planners from last week and this week yet, but we've got some ideas that I'll share at the end. The whole team is involved. So our patient services team, our recall team, workflow, everyone understands what we're trying to achieve with groups, and that's our go-to appointment. So for diabetes, it's worked really well. Hypertension, it's working well now. COPD is a little bit newer to this group of people, so it's about spreading the word, really. So really do think about your long-term goals. Our one-to-one appointments, people have to wait about 3 to 4 weeks, whereas to be seen in a group, it might only be 1 or 2 weeks at the most, so they can be seen much quicker. We have morning and afternoon groups. What did we do for our COPD? So we followed the same sort of session plan that Helen shared at the beginning. We altered it slightly. So we'd heard from this group of people that they don't like having so many texts and questionnaires. They found it hard. They're slightly older age group. So we pulled together a document that we've put in our CAT score, the PHQ-2, which prior to groups, we hadn't been asking anyone about their low mood. So that's been really enlightening. MRC, they've got a pack we put on there because we were doing it at the town hall. We wanted to talk to people rather than having computers on. So I filled it in at the back with the number of SABAs they'd had, which one they were using, and the different types of medication they were using. So we had it all in a piece of paper that they could refer to. When they arrived, they started filling in their MRC together, their CAT scores. There's lots of discussion, checking out their SATs results together, and there was a little bit of discussion. So having got the consent, we then had about 20 minutes where people started filling this in, talking to their peers, started to form some relationships, and we started filling in the table that was up on the wall. From there on, then we went to our facilitator after the questions. So we started off, because this was very new, I had myself and a healthcare assistant at the beginning, helping people fill in their questionnaires, doing SATs and such. Then we stepped back and the facilitator gathered the questions. And you really only need 2 or 3 questions to get a discussion going. You don't need to gather lots of questions. In fact, you're better off having a good debate around a few things. So we gathered our group discussion. And then it was a discussion. Interestingly, every single question that came, every single group, sorry, we've done 6 groups now in the last a week, every single time, what is an exacerbation? Because we had it up on the table, people were saying, well, what is it? How do I know how many I've had? Now, I've been seeing these people for the last couple of years. I know I've been asking them and we've been talking about it, but in that 20-minute appointment, they really weren't retaining it. And we did find as well with the diabetic groups, the first question initially 6 years ago was, what's an HbA1c? So like Rupa was saying, people don't necessarily understand the language we're using, or they haven't taken it in those last 20 minutes. The second question was always, when should I use my steroids and antibiotics? So it was really interesting. We had some really interesting discussions around that. And we also discovered that when we had the care plan, so we had blank care plans for people to fill in with us, none of them had noticed there was an amber section. So they were taking their preventers, hopefully. They might be using their blue one, either not enough or far too much. And then they were going straight to, I need to call the doctor, and I need antibiotics, and I need steroids. So what were the initial outcomes? We definitely found people learned from experienced patients. So there's some fabulous discussions, and they're often far more direct than we are. So I might have talked about smoking in every appointment I've had with someone who's with COPD and smoking. In the past, I've used visual aids and such, and not necessarily making inroads. And I'm a non-smoker. I've never smoked. I don't really understand it. We had some brilliant discussions about smoking. So the people that had already given up were sharing how they'd done it. And the people that were struggling were asking them questions. But quite a few times I had one patient say, well, that's a cop-out. Stop making excuses. Just do it. And that's something that as clinicians we would never say. So they're really quite direct. But people will take it from other people because they've actually given up smoking. They're not just talking about it. People that have been resistant to some discussions in the past actually just change their mind, especially about medication changes such as statins or changing their inhaler swaps and lifestyle changes. So because it's more of a discussion and you're bringing everyone into that discussion and they're leading it, so you're just facilitating the answers and correcting things that might go wrong and finding out answers for them, they're far more receptive to that discussion, really what they should be doing. So they're more likely to make changes. We've really tried to reduce our MDI prescriptions, and interestingly, in the group, far more people wanted a DPI. They really wanted to make changes, and the people that needed an MDI understood why they needed a spacer. And again, sometimes people were saying, I never used to use a spacer. Laura convinced me, and now I'm doing it, and actually it's way better. So they had time to look at it, practice it, see what other people were using it, and they're really interested in the diverse range of prescriptions that everyone has, really understanding that there's no one size fits all. They all definitely wanted to know what their oxygen saturations were, and they're really keen to check inhaler technique as well, which is often something you're trying to squeeze in 20 minutes. It's quite hard, but they see someone else trying something out, a new inhaler, and it's like, well, actually, I want to go, and that inhaler is much smaller than my one. I would like that, please. So they would do that as well.
Laura.
Yes.
Laura, sorry to stop your flow, but you did ask me to mind your time. So just one more minute, please.
Okay, I'll speed up.
Thank you. Thanks.
No, thank you. So lots and lots of benefits. And from my point of view, definitely, I come away from all my groups feeling far more energized. I learn lots from people that I can take to other groups. So that's really useful. I think from our next steps, I would say multiple benefits. We're actually recruiting more facilitators. So we've got a team of facilitators. We're training more clinicians. We made assumptions. So we thought that all the people with COPD would want letters rather than a text, which meant that they didn't get a link to the video that we've made. So we've now followed that up, and we're looking at our session improvement planners next week to really see how we can make some changes for the future and improve that. If there's one piece of advice I would say is absolutely just do it, go for it, but actually use the ELC guidance as well, because they've used session improvement planners, they've learned from lots of people, and it does work. So hopefully that was helpful for everyone.
That's brilliant. Thank you, Laura. And, you know, thank you for coming. It's very brave to come when you only did it for the first time the other week and share your story already, because we do know, don't we, that it does take a little while to improve things. By the time you've done another couple, you'll be absolutely on top of it. But it sounds already as if you did have a huge positive experience and saw the power of bringing people together. So I'm going to pass over now, if we could go to the next slide, to Carolyn and to Rosie, her colleague, who are going to tell you about their experiences last winter. And I think it's really useful, perhaps, Carrie, to set a little bit of context around this. So I know this was something that you were planning to do, and then suddenly Strep A happened, didn't it? And so it made what you were doing even more valuable. So do give us that context as you set us up here. So over to you guys.
Hi, thank you so much. I'll kick off first, and then Dr. Rosie Marsh will come in with the actual programme bit. So just to let you know, so my name's Carolyn Matthews, everybody calls me Carrie, and I'm actually the Haringey Training Hub lead, head of workforce development. And I support workforce across NCL for clinical Rs. We're always looking at new ways of working, and I was introduced to Georgina and to Helena very early on, about way before COVID, actually, wasn't it, when we were actually starting looking at the VGCs and how it was going to work. And the amazing thing is we've got our own train the trainers now who are supporting and been doing this for a good 3 years, and now another year in training up more and more facilitators. What happened is Islington were, if you like, a bit more ahead of the game with the other boroughs, even though I was trying to get that engagement of looking at how can we use VGC to support things like reducing access to A&Es. So Dr. Rosie Marsh was working with her PCNs in Islington, who came up with what they're going to do, and she will explain. But it was during actually that process we suddenly were able to interrupt our training when Strep A came out as a problem, and we managed to run video group consultation webinars to be able to support patients straight away. So it was amazing how you could divert what you were doing to actually a crisis that was going on there and then. So it's been a fantastic vehicle. I'm now going to hand over to Dr. Rosie Marsh, who can actually talk about the amazing work that we've been doing. Thank you.
So hi everyone, thanks for giving us your time. So my name's Dr. Rosie Marsh. I'm a GP in Islington, and I was working in for South Islington PCN doing this project, and this was a project that they funded out of their winter access funds last year. And the aim of the project was to try and reduce the pressures on urgent care and A&E access for under 5s with minor illnesses, because everyone was very aware that this was a very big pressure on the service, especially over winter. And so we decided to try and introduce some parent interventions, and we thought about how to do this, and we did some work reaching out to parents, and we thought what we probably need to do is have a very accessible form of reach out to reach the 80% with 20% of our effort, and then a more outreach based effort with 80% of our effort to reach 20%. And to reach that large number of parents, what we hope to do was use a virtual group clinic platform to reach them. So if we go on through the slides, sorry, I don't know who has control of the slides actually. Can I navigate them, or is somebody else in charge?
Rosie, I've got them. It's Helen here. So just let me know when you want to move.
Fantastic. So
am I on the right one yet?
Yeah, so if we go ahead one from here, oh, hang on. So what we chose to do was to try and improve the well-being of these children and reduce their contact. That was essentially our intervention. If we go on to the next slide, we'll just talk through what we did in order to do this. So our initial rollout was to try a full virtual group clinic setup. So what we wanted to do was to have small groups in a virtual group clinic setup where everyone shared information and we had full transparency and confidentiality agreements, etc. We tried to do that, but found there were lots of barriers to people joining the groups. This is a group that weren't necessarily very tech savvy, and being able to exchange all the information for the confidentiality agreements and things before people joined the session proved a barrier to access. So we tweaked our arrangement slightly. So there was a slight variant on the normal virtual group clinics, where we gave parents a link directly from an Eventbrite invitation to join the group, and then we went through the confidentiality once they had joined the group with our facilitators. And it was at that moment in time that the Group A strep epidemic hit. And so suddenly there was this enormous demand. So we had just put out our publicity for these programs, what to do when your child has a fever, and suddenly everybody and her sister wanted to come along and hear what do I do when my child has a fever. And so we got overwhelmed with demand, actually. So it was actually very lucky in a way that we'd reduce some of these barriers to access. And perhaps that's something that's helpful in people I've seen in the questions things asking about the admin burden. And maybe it's worth thinking about whether there are tweaks that you can make to make a session more accessible, to change how those confidentiality arrangements work for different types of clinics. So going on, having set these up and invited all our patients, we did our publicity through text messaging. So GPs sent out text messages to all of their parents of under 5s in the region, and they were given an Eventbrite link that they could click on to join.
Next slide, please.
Yeah, if we go on to the next slide. So this is the link. So when they clicked on their link, they went through to this Eventbrite page, and they were given this title of "What do I do when my child is unwell?" And they clicked on the link, and they then got an email back which gave them the link to the Teams meeting. So if we go on, we'll hear a little bit about what happened in those early sessions. So we were massively oversubscribed in our initial pilot sessions. So we responded to that by just expanding the sessions. We completed 3 sessions in December 2022, each with at least 50 participants. Then we did monthly sessions going on after that. But the December ones were really the ones that got that Group A strep demand and had that massive participation. So if we go on to the next slide, we'll talk about what actually happened in those sessions. So We looked quite carefully at who came to our sessions, because we were aware that we might not capture everyone. We thought maybe we're going for the low-hanging fruit in these sessions, the people who are tech savvy and can join them. Maybe we're not getting everyone. So we looked at the indication, the IDACI, which is the sort of deprivation index for children, and we actually discovered, much to my surprise, that we were reaching really the most deprived section of the population in these clinics. It was the biggest uptake was from the first decile. Now, that partly reflects the population we were dealing with. I think the average for children in this area is about third to fourth decile, but it's actually even skewed to that compared to the average. I think part of the reason and part of the feedback we got from parents that it worked so well was that parents of young children are very busy. It's quite difficult to attend clinics with your child in tow, and being able to access this virtually meant they could do it in the evening after they put their child to bed. We ran some at 8 o'clock or at 10 in the morning once they dropped older children off at school, and they had that window of opportunity at home. They could join a virtual group. We got parents attending from all of the different areas of South Islington, which was where we were targeting, and we did get attendances from the wards that had the highest A&E attendance, which was Bun Hill in the south. We also got attendance from all of the GP practices. Some of them had higher levels than others, and that reflected how much they engaged their patients in terms of reaching out to them. But we did get some attendees from everyone. So we were really happy with the access that parents got to these sessions. If we go on to the next slide, we'll have a look at what the perception of the sessions were. What we presented to parents was we gave them a brief sort of bit of information about what fever is, about what minor illness is in the child, which took about sort of 20 minutes or so. And then we went through a worked example using a resource called Healthier Together, which is an interactive sort of website or app resource. So they could go through that on their phone while they were watching the webinar, and we went through the sort of screenshots of what they would see. And it just showed them a really pragmatic, simple way of assessing their child, working out how unwell they are and what next step to take. Do I call a GP? Do I go to A&E? Do I manage them at home? And what could they do to help them if they do stay at home with them? We found that the parents, we tested confidence pre and post session in 2 domains. One was in managing their child's illness, and the other was knowing how to seek help and where to seek appropriate help. And we found that we got an increase in confidence scores across the board in both of those domains. And we also got some very, very positive sort of qualitative feedback. So if we go on to the next slide, we'll see some of the quotes from parents who, apologies, it's coming on the next one. I'll come back to the qualitative one in a minute. Here we are. So we got some really encouraging qualitative feedback back from parents who found it a very good medium. They found the understanding was very good, and that they got the information that they wanted, and they found this way of interacting very successful. We also had a Q&A at the end of the session, so parents were able to ask sort of specific questions as well. We'll go back again, sorry, slides in the wrong order, and have a think about actual outcomes for patients. So this is what we saw in A&E attendances over the winter, and the dark green line is Camden and the light green line is Islington, and you'll see that for the past 2 years those lines sort of tracked exactly in terms of numbers of attendances. But over this winter we did see a 7% reduction in attendances from Islington children, and that was a significant figure when we calculated the sort of statistical significance of that. Now, it's quite difficult to say that it was only our intervention that achieved that. There were actually lots of other things we were doing to try and get these Healthier Together materials out, and we were working with health visitors and things like that. And there were lots of other things going on as well, but maybe we helped make some of that difference. So if we go on to the next slide, and we'll jump on again because we've done that already. What were our next steps after this sort of big burst of activity with the Group A strep epidemic in December? What we wanted to do was try and embed this as a way of reaching parents, and so we worked with the health visiting services and the children's centres to try and embed a programme of addressing the parental minor illness management. And these parent sessions were part of the universal offer because they were relatively low maintenance to provide. It was something that we could go on offering universally at low cost. So we were able to offer a sort of monthly option to join them over the coming year. It was also possible to do some tailored in-person sessions that we could reach out to specific communities, like we did a session to the Somali community. The administration, and so I know someone's talked about the burden of administration. The burden of administration was actually handed over from the training hub to the Bright Start team, who are the health visiting and children's centres team. And it was not a big burden, I should add, but they willingly took that on because it allowed them to spread it all across the borough and to use their own communication streams to reach parents. That was our sort of plan, next steps as of last winter. Is there another slide after that one? I just want to think through sort of when we review what happened and think of our successes and challenges. So successes were in the midst of that Group A strep outbreak. Our uptake was fantastic initially. They were a very efficient way of reaching parents. We had also a very wide demographic of uptake, much wider than we actually expected. We also had excellent feedback from the parents. So it really was both qualitative and quantitatively. We got increases in confidence and parents really appreciated the sessions. And it was a very cost-effective delivery system to reach these parents. Challenges. So the challenges that we faced were ongoing engagement. So we had this fantastic burst of activity in December, and then the ongoing monthly sessions coming into spring and summer. Unfortunately, the uptake dropped, and when we sort of reached out to parents and tried to work out why, the big barriers were that we were trying to reach parents before their child was unwell. And when Group A strep was all over the news, they all wanted to know about it before their child became unwell. But when it goes out of the news, it became much more difficult to reach their parents until that moment that they were worried. We also sort of came across some barriers in specific groups, and as I said, there's that 80-20 split, isn't there? So it was that reaching that specific group. So we did start doing some outreach sessions in person, face-to-face sessions with some groups that had the biggest technological and language barriers. So I think we're coming to the end. I think is there one more slide after this one?
Only your contact details, Rosie.
Fantastic. So we are. I will wrap up there, but to say that this essentially was a fantastically good medium for that, really urgent delivery that we needed at that point of increased demand last winter, and the way of delivering and the patient feedback has shown that it was a really effective innovation. And the key challenge really is that maintaining demand when the focus is less heavily on this subject of minor illness.
That's amazing. Thank you so much, Rosie. And it's brilliant that we've got this kind of documented now, and we really need to get a case study from you as well, I think, so that we can share this. We've had a few questions in the chat, but to be honest, not that many. So I'm very aware of time, and we want to make sure that you know about what resources are available to help you. So just to confirm that this is a QOF review, if it's the models that you've heard about from Laura and Rupa, and that you will be able to count that and do your QOF paperwork just as you wanted. The percentage of people who usually in any pathway, we work on a percentage of at least 50% of your patients you will be able to see in group clinics rather than in a one-to-one appointment. The others, it might be that you're combining them with some other thing that they're seeing you for at the same time, or they've got multiple comorbidities and you look after them a different way, that kind of thing. And we can talk a little bit more about getting patients to engage with this, but we've got lots of resources like little videos and stuff. But the secret is to say, this is how we see you now. That is the secret. And I know that that's what Rosie and sorry, not Rosie, Rupert and Laura would say in response to that question. So I'm going to hand over to Helen now so that she can share with you some of the resources that we've got available. If you have got any other questions, do put them into the chat, and I'm sure our speakers will also answer them in the chat.
Lovely, thanks, Georgina. So we've just got a couple of minutes left. So you can see on the screen now, there's a couple of webinars coming up that you can book onto. There's a fuller program as well, which is available on our website. And we will send these dates out to you as well in our follow-up email.